It'll be very easy to give this talk, given the introduction that Gordon provided before. Now, as we heard, the issue of defining ARDS has been always controversial. And this level of discussion has been, if possible, even been increased by COVID-19 pandemic for a number of reasons that I will examine during my presentation. But the first one that is not listed in this slide is that for the first time we had a huge amount of patients with what was so-called ARDS, and even my mother was able to understand what the hell I was doing for a living after 30 years. Even my mother nowadays knows that ARDS exists because she saw it on TV, and everybody was talking about ARDS. You saw this slide. This is the first paper that reports the term ARDS. And what in this paper the authors concluded was they essentially identify a subset, an endotype, we would say nowadays, of 12 patients out of more than 250 patients, all with acute hypoxemic respiratory failure, that they were characterized by a number of clinical and pathological variables. And this was the basis that took off the term ARDS. Few years after the publication of this paper, at that time was American Review of Respiratory Disease, published two editorials, one from Thomas Petty and the other one from John Murray. John Murray say, ARDS, may it rest in peace. Petty said, well, I'm a pure lumper and I think ARDS should exist. Now that was few years after the publication on Lancet using for the first time the term ARDS. Many years later, we got exactly the same picture. These are two editorials published in the COVID area, one saying ARDS exists and must be actually adapted to what we learned during the COVID-19, and another editorial saying, because of what we learned during the COVID-19, we should get rid of the terms ARDS. Now, if you see this pendulum of arguments keeping going, keep going, something that must be wrong in the basis of the logical process that led us to the concept of ARDS. But I want to, and this is in line with what Gordon said, I want to focus your attention on these words used by Martin Tobin that wrote a letter commenting our paper on the Blue Journal. And because Martin Tobin is a distinguished and well-known academic intensivist, and he challenged all this discussion we had in the last 30 to 40 years about the ARDS, saying, who cares? Who cares about that? The clinician at the bedside does not need an ARDS definition. And actually, it was quite provocative, and I don't want to get into this because he's not here and it's not correct to debate with someone who's not in the audience. But that's what he was challenging, the basis it was challenging. Stop with this crap. I mean, we don't need ARDS. Let's take care of the patient based on physiology. And I remind you that I started this enterprise as an applied physiologist. But let me answer to Martin Tobin's challenge, why we need formal definition and how we should create them. Now, the answer to the first question was already provided by Gordon, because it allows the inclusion of similar patients in research, which was a point that Martin later was dismissing as totally irrelevant. But I think we need clinical studies, and without an appropriate definition, without appropriate inclusion and exclusion criteria that can be used by anyone around the planet, we don't take our field forward. And to provide therapeutic and prognostic information to the clinicians, to the patients, to the family. Of course, there are also administrative elements, but I'm out of them. So, how should we create a definition for ARDS or for other syndromes. Now, I would start with this editorial by a psychiatrist published in the early 90s, where he described the process that psychiatric field took in order to define what they treat every day, and they treat syndromes. They don't treat disease as well as we do. And the words he used to describe the process was evolving from the great professor principle to the consensus of experts to a scientific system of categorization. And if you think about it, this is what happened to our field. We started with the great professor principle. We ended up with a consensus of experts, and we tried, and this was probably the most relevant contribution that the Berlin definition provided, tried to apply a scientific system of categorization. So this is where we should go. Now, as discussed before, there are a number of open issues with the ARDS definition. The fact that we should use oxygen saturation instead of arterial blood gases. The fact that we are using high-flow nasal oxygen that would not allow nowadays, based on the Berlin definition, to define a patient as having ARDS. The fact that the Berlin definition is problematic in resource variable settings because they need chest X-ray, arterial blood gases, mechanical ventilation is not always available, because due to the fact that chest X-ray may be problematic, and because it's very complex in some contexts, nowadays we have ultrasounding, because many are proposing the concept of getting rid of the ARDS definition and use hierarchical approach, the big umbrella, endotype, phenotype, all that stuff. But I don't want to enter this. I will not give any slide on any of these aspects. What I want to focus is what is the methodology we should implement nowadays if we decide we want to work on the definition of ARDS. And this is what is about the article that we published a few weeks ago on the Blue Journal. All the article is based on 2 books. Most of the article is based on 2 books. The first one was published in 1987, and the second one is more recent, was published in 2012, 2014. And based on the concepts that were described in these books, concepts that have been implemented in many fields of medicine, that have been implemented in other fields of science, sociology, psychology, and others, we need to adopt some methods if the target is to develop a scientific system of categorization and provide a definition of ARDS that is based on science and not based on the consensus of the great professors. There are some concepts that we need to adopt and implement in our scientific practice. First of all, abandon the concept of syndrome and adopt the concept of constructs, and then systematically apply the concept of reliability, feasibility, and validity in order to provide a definition, understanding what is really meant by reliability, feasibility, and validity. Constructs is, in a way, a philosophical concept, is to agree on the words, on the terminology, so that everybody is able to understand what he's talking about. Now, this may be irrelevant in some perspective, but is absolutely crucial. Let's say, how do you define intelligence? Intelligence can be defined in many ways. So if we don't create a common language that is able to describe intelligence, frailty, and so on, we're not able to communicate. And that's why many authors in fact, as a matter of fact, say what we are used to call syndromes in medicine are in fact what psychologists call constructs. So constructs is a systematic exercise to agree on the language. Why the language is important? I don't find any other way to understand, and that's why I'm trying to propose to you the meaning of construct and the importance of the concept of construct using Confucius. Confucius' pupil was asking to his master, if they ask you what would be the tool that you as administrator of a kidmon would use, what would you do based on your philosophy, based on your wisdom? Confucius says, I would make sure that words are used with their correct meaning. And the pupil said, why? I mean, you are the administrator of an empire and you care about words? And Confucius said, yes, because if words do not correspond to reality, it's impossible to create positive relationship among individuals. And I think this is the best description of what I mean and what we meant in our article. Now, let me go fast through these concepts. Reliability, in the context of assessing a new definition, is defined as the ability to say that patient A has the syndrome, and this is true for me, is true for him, is true for him, is true for everybody. So we are able to, again, the language is able to identify the same reality wherever you are, whoever you are. Feasibility means that you have to be able to use these criteria everywhere without any limitation. Of course, chest CT scan may provide a better signal-to-noise ratio in terms of identifying what we have in mind as ARDS than a chest X-ray, but we can't do it everywhere and every time. Validity is the capacity of a test, and we don't have tests to make the diagnosis of ARDS, or a definition, to capture what the investigator is actually looking for. Now, if you have a gold standard, it's easy. I mean, you assess the validity of your test or of your definition with sensitivity, specificity, and accuracy. That is well-established statistical tools. But when you don't have a gold standard to refer to, and we don't have a gold standard, still don't have it, you can empirically assess the validity in terms of predictive validity, where predictive is to predict in terms of outcome, to predict in terms to response of therapy. And I stress your attention to the and or, you can use phase validity to validate your definition. That is, we all agree that in our gut, using those words, we identify the same patient. We, the royal we, everyone, everywhere. Now, in that article, we concluded with a very busy slide table of what should the process be for approaching a definition of a syndrome, the definition of ARDS. But let me summarize some aspects. First of all, as Gordon said, we need to know when we approach this what is wrong and in which way we want to make it better. And this has to be clarified upfront. Now, we need to explicitly clarify the language we are going to use to describe the process. Now, who should provide a definition? If the language is crucial, who should provide the language? Since we want to move from the great professor idea to a scientific approach, the only way we should follow to provide an upgrade of definitions is through scientific societies, and not as individual groups of investigators. And the criteria that are used to create the panel that is providing this definition has to be transparent and has to be declared upfront, and should be include all diversity along the multiple domains of diversity. And this doesn't have to be politically correct, has to be politically effective. And we should define as experts not just the clinical scientists, but also the clinical practitioners. And the group should involve both identities, should involve all healthcare professionals involved in the care of these patients, and should include patients and family representatives. Now, the validation process should start with the hypothesis that ARDS has X and non-ARDS does not have X. And we should clearly define the variables that we should investigate. But let's say we don't end up with any variables that is able to provide a sufficient predictive validity. We are left with phase validity, and there is nothing wrong with that. There is absolutely nothing wrong with that. Psychiatrists treated schizophrenia, successfully treated schizophrenia for decades using just phase validity to define schizophrenia. Phase validity is not, forgive me, a mental masturbation exercise. If we don't have A that identify ARDS, we should use phase validity. But we must do it following the rules that have been provided by other fields of science. And I said we should follow the triplet, no? Reliability, sensibility, feasibility. But we have to understand that there are trade-offs in this. Let's say you can get a definition that makes in conflict reliability with feasibility, then you have to choose. And you have to declare at the beginning that you give priority to reliability instead of feasibility. And validity is a continuous process. You don't end up with a definition that stays there forever. And there is nothing wrong in saying this is the way how I consider my syndrome, but we need to check in 2 or 3 years because it's an evolving concept. And that's a crucial aspect. Validation of a clinical syndrome is not a statistical exercise. There is no rocket science in terms of statistical model here. It's a clinical problem. And we need clinicians, and clinical scientists to solve this problem. So this is the paper, and let me conclude thanking a number of people. First of all, my co-authors, because it was an incredible intellectual exercise. I know it's going to be boring to read it, but for me it was extremely fun to write it. Let me thank the editorial board of the Blue Journal, the reviewers, because they provided an outstanding work. I've been doing this for years, but this has been one of the most exciting experiences in terms of the reviewing process. And let me thank Gianrico Carofiglio, who is a book writer, my schoolmate from Bari. In Europe he might be famous, in Italy for sure he is, that provided me the Confucio quotation. Thank you very much.